Next 20 minutes, I'm going to be probably talking about things that are largely review for most of you here, but there may be a couple of things that are new. Some of the acknowledgments and disclosures, none of which really have anything directly to do with what I'm going to be talking about this morning, except for the support from NIH and HRQ and PCORI. Talk a little bit about nomenclature and the standardized nomenclatures that's out there as far as how we should be describing various things, and then talk about degeneration and what the spectrum of normal is and how that affects what we talk about. So classifying findings, I don't know if you can read that. I can cure a back problem. There's a risk you'll be left with nothing to talk about, and that's I think often how we feel. This actually is, whenever you're talking about classification systems, you want them to be simple and straightforward and not a lot of work. This is actually a drawing that my daughter did, I think, when she was 5 or 6 years old and just starting school. And you don't want it to be an overwhelming amount of work for classifying things. So why is it important? Well, I think this gets to the whole concept of a learning healthcare system, and that's something that we all aspire to, and probably none of us are there yet. Being in a system where we learn from every patient, every encounter on a system level. And if we really want to have systematic learning, then we have to be able to extract useful information from the electronic health record. And in order to do that, there has to be some agreement, some standardization as the type of data that goes into that EHR. Otherwise, you just get garbage out. And so that brings us to standardized terminology. Talk a little bit about stenosis. There was a consensus meeting that occurred in Switzerland probably over a decade now ago. It was published in 2014, but maybe it was about 8 or 9 years ago. Where there was this multidisciplinary conference that got together and talked about central stenosis primarily and how it should be reported, essentially. And the bottom line is that, again, simple is more reliable, is more usable widely. And so talking about compromise of the central zone, simply dividing it into thirds, up to a third is mild, a third to 2/3 is moderate, greater than 2/3 is severe. This was used in the SPORT trial, and again, has some predictive value, has some correlation with clinical exam, although not great, and that's just in general an issue with central stenosis, is that we don't have a really tight correlation with what's going on clinically and the imaging, but at least it's a reliable description. And you compare the stenotic level to an adjacent or near adjacent normal appearing level. So on the left is a normal appearing level at the disc level, and of course highly stenotic level on the right side with the triad of facet hypertrophy, ligamental flavum buckling, diffuse disc bulge causing severe central stenosis. So this consensus nomenclature has been around for a while now. It was first promoted by Pfirrmann, who was a French-Canadian neuroradiologist, as well as his surgical colleague, Pfirrmann, and really disseminated and accepted by all of the spine societies that have anything to do with spine care. So there's a wide degree of acceptance. It was updated a couple of years ago, and I'm just going to go through some highlights. So the goals, again, practical, simple, high inter-observer agreement, and the basic nomenclature is this. Talks about whether the disc and disc level are normal, whether it's degenerated, whether there's an annular fissure, whether there's a herniation. And I just wanted to focus on herniation because I think that has in many ways the most relevance, and where there was the greatest degree of variation of nomenclature that was in there. So Herniation, this defines a herniation as a localized displacement of the disc material, and then essentially looks at the circumference of the disc. If it's greater than 25%, that's defined as a bulge, and if it's less than 25%, or if there's some focality to it, that's a herniation. So pretty simple, and just in a cartoon, normal disc is confined by the end plate, a bulge is a diffuse abnormality of the disc, and then you have herniations, and herniations are subdivided into protrusions and extrusions. So protrusion and extrusions are both focal abnormalities of the disc. The definition of an extrusion is that the largest diameter of the herniated material is not adjacent to the parent disc, or in other words, it has a neck associated with it. And that can be either in the sagittal or axial plane. And this is the cartoon from the nomenclature article demonstrating again the difference between a protrusion and extrusion. Just some examples of bulging disc, and again this is nothing new to you. Sorry, this is projecting a little bit fuzzy. Central protrusion, you can see an annular fissure, which is that high signal linear signal at the periphery of the annulus. And then focal abnormality, largest diameter adjacent to the parent disc, so it's a protrusion, and extrusion, largest diameter is not adjacent to the parent disc, so it has a neck associated with it. Pretty straightforward nomenclature. And the next question, and just some more examples in the axial plane. What's the reliability of this? When anybody comes up with a new classification scheme, you should say, how reliable is it? Because if it's not reliable, it's not useful. And so when talking about categorical reliability, the standard statistic or widely used statistic is called the kappa statistic, which essentially accounts for the amount of agreement that you would get by chance. And you're essentially shooting in general for kappas in the 0.6 or higher range to say that this is a reasonably reliable classification system. And if you look at intra and inter-rater reliability, it's pretty good. Actually, it's sort of just right around that 0.6 threshold. So that's the nomenclature that we should be using, we as radiologists when describing disc abnormalities, and hopefully you as the end user understanding what we're trying to describe. There's another classification system which talks about the nerve roots and describing the neural elements as well as the discs. And again, it's a simple classification system. The neural elements are either contacted, displaced, or compressed. Here's a cartoon as well as examples from the article that describe that. So you can have a disc protrusion, but if it's not touching the nerve root, you describe the nerve root as normal, contacted, nerve root. And one of the things about this classification, just going back for a second, when you talk about nerve roots in the lateral recess, they're almost always contacted by some disc material that you can see. So then the question is that just part of a spectrum of normal? Do we actually describe that? Is that useful to describe that, or is it potentially misleading? And I'll get into that a little bit later. So then the next step beyond is displaced, and then finally compressed. And essentially the way I treat this is that if I cannot distinguish the nerve root from the disc material of the hypertrophied facet, whatever's compressing it, I call it compressed. Another example of compressed nerve root here. So again, the question is, what's the reliability of this Pfirrmann nerve root grade? Pfirrmann's the Swiss musculoskeletal radiologist who described this, and quite good. Again, we're shooting for those kappas of about 0.6 or higher, and it's well above that threshold. So just to see if anybody was listening, an example of disc abnormality, and think in your mind, is this bulge, protrusion, extrusion, or prolapse? And of course prolapse is not part of the consensus nomenclature. So key question is the largest diameter adjacent or non-adjacent to the parent disc, or does it have a neck associated with it? And of course, it's an extrusion. So, all right, so that's whirlwind through nomenclature. Does anybody have any questions about that? Okay, so spectrum of normal. So clearly an issue that we face in the spine is that whenever you image anyone over the age of, pick an age, 20, 30, you'll find something. And the problem is that many of the things that we see are not associated with what's causing somebody's pain. There have been a lot of studies out there looking at the prevalence of various findings in people without back pain, going back to the 60s and looking at myelography, and then in the 70s and 80s with CT, and then the 90s and later with MR. You can essentially pick many findings and find a relatively high prevalence of people that don't have back pain. So just looking at herniations specifically, you can see about a quarter to a third of people will have herniations who don't have back pain. These earlier studies, of course, were before this distinction between protrusions and extrusions. When you look at the later literature, there's this breakdown that you see protrusions are quite prevalent, extrusions are not. And so that's one of the reasons why this has been incorporated into the consensus nomenclature, is that extrusion implies a rarer condition, which presumably has a higher correlation with someone's clinical symptoms. And here's just an example from a study that we did at the VA here a while ago now, probably 20 years ago. We call this the laid back study. It's probably my proudest accomplishment as an academic, coming up with that acronym. It was longitudinal assessment of imaging and disability of the back. So it's actually relevant. And so these are 3 different asymptomatic patients. They were all rigorously screened for current back pain. We couldn't exclude anybody that never had back pain in their lives because we wouldn't get anybody into the cohort. But they couldn't have had back pain for the prior 4 months at least, and never had surgery and never had severe back pain that required medical treatment. And so you can see a whole variety of things, including desiccation, height loss, bulging, listhesis, fissures, all sorts of things that one can see in some people without back pain. So if you look at the prevalence of degeneration broadly defined in people who don't have back pain, you can see that it's quite high, half or even 3/4 to maybe even more, depending on what age group you're looking at of your cohort. So another way of looking at this is that if you don't have disc degeneration, you're distinctly abnormal once you reach a certain age. So, of course, the problem with that is that, how do you ferret out all of these highly prevalent findings in people that don't have back pain and are probably clinically not important from those that are clinically important? And what is the impact of us reporting all of this stuff on patients and primary care docs and specialists who end up needing to explain all of this stuff to patients? And so back a while ago now, this is back in the 1990s, Martin Rowland and Moritz van Tulder published an editorial in The Lancet, which essentially called for a change in the way that we reported imaging findings of the spine. And what they called for was essentially putting in normal values into the routine radiology report. They were talking about plain films, and their recommendation was to say X% of people who don't have back pain will have this finding, to put into context for, again, patients as well as primary care docs who may not be as familiar with this information, what a particular finding may mean. So we thought this was an intriguing idea, and we just started incorporating it into our reports and, over at Harborview first, and this was, again, quite some time ago, probably about 10 or 15 years ago. But we were doing it without any evidence of what it actually does. And there was some concern that by putting in this prevalence information that you might steer patients away from necessary care, that their outcomes might be worse. But the hope was that we'd be steering them towards better care. So we actually have put together this large pragmatic trial, which is the lumbar imaging with reporting of epidemiology study. Everybody wants to call it LIAR. I don't know whether that's a comment on radiologists in general or just specifically what we talk about with spine imaging. But what I was thinking was LIAR, which is the French verb to read, because it's all about reading and understanding what we're putting in radiology reports. So this was a large pragmatic trial, which was sponsored by NIH, the Healthcare Systems Collaboratory, and this is a branch of NIH which is not associated with any one particular NIH institute, but is funded by the Common Fund, which is the director's money, and it was a special effort that he has put forward to do pragmatic trials, which means clinical trials in real-world settings. So it's effectiveness research, asking questions of how does something work in a large variety of usual practice settings, as opposed to single center, highly specialized studies which may have big generalizability problems. So supported by the Common Fund, and the whole idea behind the collaboratory is to build the infrastructure for comparative effectiveness research. There are probably about a dozen large pragmatic trials which are being funded by the Common Fund currently, just spanning the entire gamut of healthcare. And ours is the one that has to do with spine care currently. So our hypothesis was that, and again, focusing on primary care with the thought that it really is the primary care setting that they could use this essentially educational intervention. So inserting this benchmark information, this essentially normal range into lumbar imaging reports would potentially reduce unnecessary cross-sectional imaging, opioid prescriptions, injections, and surgery. And we actually had some pilot data to suggest that those things would happen from Harborview. Again, this was a retrospective small pilot study that I think Brendan McCullough was actually involved in when he was a resident and fellow. But what we essentially showed was that there was a reduction of subsequent imaging in patients that did versus did not get this additional information. Again, it wasn't a randomized trial. When we introduced this, it was optional as to who put it in and who didn't put it in. So some people did, basically me and Quinn did, and nobody else did initially. And so it was arbitrary, not randomized, but we were then able to look at what happened downstream to the people that didn't versus didn't. And one of the sort of more intriguing things was when we looked at narcotic use within 1 year, that again, there seemed to be a difference just from this very simple intervention. Now, there could be residual confounding and potential bias that's entered into this, but it was intriguing enough that it actually got us funded through NIH. So this is the intervention. It's pretty simple. We actually have 9 different flavors of this intervention text because we have 3 different age groups that apply to, that we use it for, since the prevalence of various things changes with age. And then for 3 different modalities for plain film CT and MR, since the things that you can see are different on each of these. This gets inserted into the radiology report. And then being a pragmatic trial, we're collecting the outcomes passively from the electronic health records. And the outcomes are essentially utilization outcomes that we're looking at primarily. Just to give you some idea of the scale of this kind of trial, this pragmatic trial. We're doing it at 4 integrated health systems. We wanted to make sure they were integrated so we could have a be reasonably confident about capturing all the important subsequent utilization. So we're looking at, Group Health, or now Kaiser Permanente Washington, Henry Ford in the Detroit area, Kaiser Northern California, and then the Mayo Health System. That's not only the Mayo Clinic, but they actually have this large primary care health system across Wisconsin and Minnesota. And so you can see we've got nearly 1,700 primary care providers enrolled. And the trial is closed at this point, but we enrolled about 250,000 patients into this trial that we're following up to 2 years to see what happens to them. And our primary endpoint is 1 year. That's going to be actually at the end of this month. And so we're going to get our last data pull over the next couple of months and be able to see what impact this has had. But at this point, we don't have results, but we have this wealth of information about, these are all primary care patients that presented with spine imaging. So we know that that's what defines the cohort. And across these 4 healthcare systems, we have all of the EHR data, all of the billing data, all of the medication data that's associated with these patients. So we can actually start to explore lots of sub-questions, and it is going to be this great resource that's available to anyone that's interested in spine research. So just as a review, prevalence of disc degeneration in older adults without low back pain. Again, no secret that it's incredibly high. So in summary, I think use standardized nomenclature wherever possible. Since Dan and Brendan were, trained with us, I'm sure that they are using that. It's good for everyone. Many findings common in asymptomatics. 3 findings more likely to be clinically important, which are extrusions, root compression, and central stenosis. And I think I'm out of time. Thanks for your attention.